Hi, my name is Michelle Ginsberg. I'm a radiologist and I'm Director of Cardiothoracic Imaging and Vice Chair of Education at Memorial Sloan Kettering Cancer Center in New York City. Certain morphologic features can certainly be suggestive of one histology over the other, but by no means are they definitive. There is some significant overlap with these histologic types, but there are also certain characteristics. And to go into that, adenocarcinoma, which is the most common cell type, and it's most common in non-smokers. And generally, it's seen as a solitary peripheral nodule or mass. Often it can be subpleural. That's why it's more likely to be peripheral. And because it is peripheral, patients are usually asymptomatic because they don't present with any obstructive symptoms. It's generally further out in the lungs. And that may, a peripheral lesion may be more likely to be an adeno just by location, for example. Other things that could help us are the attenuation of the nodule. If there's ground glass within a nodule, because some of the early stage adenocarcinomas, the adenocarcinoma in situ, for example, or the minimally invasive adenocarcinomas are more often associated with ground glass component, a subsolid appearance, where the solid component is the one that's thought to be the invasive component. So in those types of tumors, you wouldn't normally see ground glass attenuation in squamous cell, for example. I mean, with exceptions. So adenocarcinomas of the pre-invasive types, or such as the in situ, the minimally invasive, will more likely be associated with those characteristics. Now, the invasive mucinous adenocarcinoma, for example, has a more variable appearance, but includes consolidation with air bronchograms, and it's also been called as a pneumonic type because it looks like pneumonia. It may also have multiple solid nodules or masses because it can spread. The way it spreads is through the alveoli, and more of an airspace type disease. So those are the typical appearances. Obviously, as I mentioned, there is overlap. Squamous cell cancer, which represents a smaller percent of tumors, about a third or so, grows locally rapidly and generally has a very strong association with smoking and is centrally located. About 2/3 of these lesions will be centrally endobronchial type lesions. And what that means is that if there's invasion of these large central airways, these patients will present with symptoms. And maybe because of that, may present at an earlier stage because they're presenting with symptoms. Another feature that's been associated is cavitation, which suggests necrosis. And more commonly, it is seen with squamous cell type histology. Of course, it can be seen with others, so there is overlap. But in very general terms, a central endobronchial lesion causing obstruction with atelectasis or pneumonia is more classic of a squamous cell cancer. And adenocarcinoma of more, again, very generalized peripheral lesion, single nodule or mass, more likely to be an adeno.